round out our discussion of the initial visit here so we can get to the bounce back visit and also get to some of the legal parts here because we have some trial testimony, some actual trial testimony that we're going to read in just a minute here. So the last point I just wanted to make as far as the history of present illness, that's one of the biggest things that I see as a problem in patients that have a bad outcome and then proceed to legal process, is that the history of present illness, this free history that we can get, is so often cursory and doesn't really explore some of the potential bad things. And when we look at the highlighted area that I have here, they have some of those things, a tightness across the chest, a pleuritic aspect, but there's so much else about chest pain that I'd like to know. What was the onset? Is it worse with exertion? Has she had this in the past? Is it constant or intermittent? Are there other associated things that we could think about, such as upper respiratory infections that could lead to bronchospasm, another plausible type of thing, an alternative diagnosis? We don't really see any of that. So what I'm going to do is proceed just a little bit along the way here and think about these two big things, other things that could be considered in the differential. We talked about that. As far as improving the documentation, not only with a better history that we document, but also the medical decision making. And it is possible to say something, even with this patient, like, you know, she presented with chest pain. I was concerned about ACS. However, with further investigation, I found out that she's had 4 days of constant pain with no EKG changes. When I palpate the left lower sternal border, she withdraws from pain and exhibits facial wincing. And, if you would have checked a troponin with 4 days of constant pain, and that would have been negative, it would be a plausible thing to maybe further to consider the evaluation to be continued safely as an outpatient. Unfortunately, those things weren't done. So it's always a balancing act, isn't it, between the risk of missing serious disease and overtesting and the risk of potential false positive tests. But unfortunately, that's where the scales fell with this patient. She was sent home. She was reassured. And when she got home, she still had her discomfort, but her daughter heard some noise in the kitchen around 4 o'clock in the morning and went out and found her mother sitting on the back steps. And she sat down next to her mother, who's smoking a cigarette. And her mother said something curious to her at that time. She said, "If I've ever done anything wrong, or if I've anything not kind to you or to your brother, I'm sorry for that." And her daughter thought it was curious, didn't really say much at the time. But then her daughter was woken up 2 hours later after she'd gone back to bed with a crash sound in the kitchen and came out and found her mother to be in full cardiac arrest. So here's this 16-year-old performing chest compressions on her mom, trying to dial 911 with the other line, which she did successfully. The paramedics arrived, and the paramedics were able to get this patient back, at least initially. So here's the actual summary from the EMS. They say, 41-year-old woman found apneic pulseless according to the family, was making coffee and collapsed. She'd been having chest pain for a few days. They did CPR, bag valve mask ventilation. They placed an endotracheal tube, gave the patient epinephrine. And below what you'll see is the actual squad run sheet where they wrote out their findings. The physician documentation found this rhythm strip, and they say EMS with a witness arrest by the husband. Now, it turns out that that probably wasn't actually what happened. She complained of chest pain prior to arrival, and they say on their physical exam, no spontaneous heart tones, and they was found at 5 o'clock in the morning with full arrest. So what we're going to do is we're going to look at 3 different decision points. And with each of those, we're going to ask some questions. We're going to answer those questions with in a literature-based fashion. And then we're going to see what the actual provider did, what happened to the patient, and then we're going to progress to our next decision point. And I want to leave time, and hopefully plenty of time, for some of the trial information that we have at the end. So why don't I first start off by throwing this back to Matt Delaney here. And Matt, you're in your emergency department in Birmingham, Alabama. You're with your residents. You get a call, which we've all had many times over the squad box, that they're bringing a patient in full arrest. What are some of the actions that you take prior to that patient arriving in the emergency department? And then when they get there, what information are you going to look for with the paramedics? Matt, you are muted now, so hopefully if you unmute, we'll be good. I'm going to unmute you. Can you hear me, Matt?
I hear you. Got me?
I got you now. All right. So
Yeah, I'm
some
just
of the
I'm just
actions.
getting muted left and right. So
It's
there's
nothing
I
personal.
think there's the oral boards answer, which we all know, which is get your team together, get your airway equipment, get your resuscitation supplies together. I think I've found two things that are helpful in that time period. First is I go empty my bladder. I think best with an empty bladder. So that's my first step if I have time.
Right.
And the second step, I think, really depends on where I'm working. A lot of times with residents that I have every subspecialist available. I also work at a small hospital where I'm the only person there, essentially. And so what I try to do in that time period we have, even if it's 30 seconds, is get some pre-encounter estimate of what other resources might I need. Is this, a 40-year-old goes down with chest pain, I'm thinking, is this an acute coronary syndrome? Is the CAF team here? Are they at home? If it seems like a stroke, how do I manage that within my system? So really trying to think through some of the logistical hurdles, because when the patient shows up and we're coding the patient, I find it's hard to mobilize a lot of resources. So if I can get a jump on it, that's when I do it in that time period after I go to the bathroom, before the patient shows up. And then when EMS shows up, and I mean, if you've worked a shift, you know that there's a lot of variability in terms of the story that EMS is able to get and then convey to us. But ideally, I want to know what happened. Did you get anything from the family? What did you see on scene? What was the initial rhythm? What have you done? And then one of the things that's really helpful is figure out who is coming, because if family is coming, I can maybe be able to get more information, but also that sets a little bit of a roadmap for what might family know about this situation. So when I have to kind of deal with the family and the patient, I get some preview. So really, I want as much information as I can, because I want to try to mobilize resources and give this patient a fighting shot.
I mean, even at the most basic, thinking of code status, right? And, paramedics sometimes start that code and they have a DNR bracelet on, or they have signed paperwork. So a family arrives with that. The other thing is, just like you're saying, if this was a witness arrest, that's going to be pretty different as far as our actions compared to a patient who is found down, who has a history of, metastatic malignancy, for example. Um, how about as far as this next question here, Kevin? Mechanical compressions, we see people sometimes come in, different names for it, on the thumper or whatever it might happen to be. And where I work, sometimes there are long run times. And so we know that there is compressor fatigue that happens just in the emergency department, where we can change out every 2 or 3 minutes. But you can imagine when you have a couple of medics in the back of a squad and they have a 20, 30-minute runtime, maybe in that situation, this could be better. But what does the literature show us with mechanical compressions versus CPR?
Well, I know you always like to keep these conversations moving really, really quickly, Michael. Do you want the ultra short answer or just the short answer?
I can go with the short answer.
Okay, all right, thanks. I'm glad you said that, because otherwise ultra short was mechanical, Michael. Mechanical, that's it.
Okay.
The ultra, but the short answer adds in a little more detail. So when you're looking for precision, something that requires something to be precise repetitively over and over and over again, I think you want to get the machines involved. So for instance, take a look at measuring intervals on an ECG. We're not very good at it. The machine is great. The machine is horrible at looking at morphology and understanding what that is. It requires intellect and analysis. Well, and CPR doesn't require that, but the precision of the depth and the timing, et cetera, is important. And we know that CPR is only at best, if performed well, 30% as effective as normal circulation. And really, if you're going to have great technique, most people are only going to, when they start, maintain good technique for about 92%. And then after, for your question, what the literature says, after 3 minutes, correct CPR drops off to about 39%. So because of the lack of maintenance of precision and the ability to deliver CPR effectively and the limitations with CPR from its very beginning, you got to go with the machine if you have it.
Well, I'm glad you said that. And one of the things that I see at the bedside frequently is all the stuff we do, the epi, and I mean, the shocks obviously are helpful. Epi and the medicines probably don't really do a whole lot, but the chest compressions. And oftentimes I will stand on the patient's right side with my hand on their femoral artery, feeling the pulsations. And my hand oftentimes is sore at the end of a code, because I am checking to make sure that there's good perfusion, that those compressions are being done adequately, that I can feel those. Now, I know there's a little bit of literature and differences with some of the literature on being able to palpate pulses and all, but when I can feel a good femoral artery pulse with compressions, we've actually been able to do compressions, sometimes so good that the patient is actually awake, moving their arms, even opening their eyes sometimes during resuscitation. So getting those compressions good and being a good team leader to make sure that those are being done well is super important. KK, we talk about CO2 monitoring, and that's obviously being done more and more and more. What is the role of that during CPR and during a code?
Yeah, so first of all, when they do wake up during coding, it is kind of a freaky situation, but I
Yes.
think a lot of us have seen that. But so the end-tidal CO2 is going to be a good surrogate marker for cardiac output. So if someone is doing good compressions and the 10 millimeters of mercury is happening on the end-tidal CO2, then that's a good marker that they're doing adequate CPR. Certainly using the thumper might increase that, but there's not a specific cutoff to predict mortality. And there's also not a specific cutoff to say when to call the code, when to call time of death. It doesn't really, we don't have good literature on that. But what we can say is if you have a sudden drop in the ETCO2, you're going to have potentially fatigue in your staff that's doing the compression. So it's time to switch or put them on the thumper. Alternatively, if your end-tidal CO2 abruptly increases, that could mean that they have ROSC. So certainly correlation has been shown to be a little bit better with outcomes if the end-tidal CO2 is over 20 as well.
Awesome. So let's find out what happened to that patient. So this is a scanned version from the actual sheet from the hospital. And I know the times when the patient arrested are sort of different with all those different things, but certainly we do know that the EMS arrived at the ED at 5 o'clock in the morning, endotracheal tube in place. CPR continued with epinephrine, atropine, bicarbonate. They gave lidocaine. They found the patient a PEA. But at 5:09, really less than 10 minutes later, they found a wide complex bradycardia. They started a second IV line, started the patient on dopamine, and they had ROSC, return of spontaneous circulation. So let's go to decision point B. Matt, we are now at a patient with ROSC, and I think we all know this because there's obviously a lot of literature about this, but this isn't obviously the time to start slapping high fives, walk out of the room and go see the ankle sprain, right? There's a lot more still to be done. And we're going to talk in just a little bit about therapeutic hypothermia, but without that, what are some of those post-ROSC steps that you take at the bedside?
Yeah. Did you mute me again? Am I unmuted?
It's a
There we go.
subconscious thing.
First
I just
time,
like
right.
in my brain, I'm muting you, but we're
Correct. That's
actually
the
able to
correct
hear you,
instinct.
right?
I mean, I keep this really simple. If they're no longer dead, I want to do the things that I need to do to keep them from being dead. So I want to maintain their blood pressure. I want to oxygenate. I want to ventilate well. And then it really kind of swings the door wide open in terms of, can I figure out why this patient was dead just moments ago? Honestly, a lot of times I'm stuck. I get an EKG. I send off some blood work. I may get some scans, but this is where extra history, if I can get it from the family, is helpful. This is where if I can pull up their old records in our system, but really trying to troubleshoot, why are we in this situation while at the same time trying to keep the patient from regressing back to the being dead again?
So I'm going to throw this out to everybody. Give me an example of a time that you've used an ultrasound post-arrest where you've found something that changed the patient's management. Kevin or
Tamponade.
KK or Matt? Yeah. Uh-huh.
Yeah, I mean, I'm not great with ultrasound. I think these are the patients where it's helpful, even in my hands. So I found tamponade. I found kind of surreptitiously shattered spleens. I mean, I think the use of ultrasound is potentially huge in this kind of undifferentiated, just recently not dead patient.
Yeah, I mean, when you really start making a list of all the things that you can just think up off the top of your head, I mean, there's tons of things that we could find. So super important to make sure we have that vigilance and do that, and don't stop at the time that we get the ROSC and just order some labs and walk out and start doing some documenting. So Matt, we're going to stick with you on this decision point here. You want to just go ahead and fill us in? The patient was started on dopamine. I thought was a curious choice of a vasopressor. You have a little bit of literature, dopamine versus norepinephrine. And then also, if you want to give us a little further information on the Dankowitz recently released article in New England Journal of Medicine on therapeutic hypothermia for out-of-hospital cardiac arrest versus normothermia.
Yeah, so the two parts, the vasopressor, people get really fired up about this. I keep it simple. I think norepinephrine is a good first-line agent. There are multiple studies that show that it's probably superior to dopamine. There are obviously issues with every study potentially. And so rather than get lost in the weeds, I would keep it simple. I would go with norepi for almost any patient that rolls in post-arrest. The Dankowitz article, so, if we had done this book club a while ago, a year or two ago, I think the next step would have been, is this a patient that I would think about therapeutic hypothermia? If you followed that literature over the past decade or so, the initial studies are pretty promising. They were pretty small studies, but I think most of us, starting 2013, 2014, when the guidelines started to shift and push us towards therapeutic hypothermia following out-of-hospital cardiac arrests, have started to use that as a normal part of my workflow. So the Dankowitz paper, which came out just last year in the New England Journal of Medicine, is the biggest study to date looking at therapeutic hypothermia. So 14 countries, 61 institutions. And again, keep in mind that previously, all of the studies together looking at this treatment modality were about 500 patients. So these authors did a big study and enrolled about 930 patients in the hypothermia arm, 931 in the normothermia arm. And this was looking at patients who had an out-of-hospital cardiac arrest, who had sustained ROSC. So they had to have 20 minutes of circulation without needing chest compression. They excluded the people you would not want to enroll, unwitnessed arrests who are initially asystolic, intracranial bleeds, pregnant patients weren't included. And essentially you were put in one of two groups. You either were cooled to 33 degrees Celsius. And then the control group, the normothermia group, basically you're allowed to do whatever you wanted to do from a body temperature standpoint until you triggered the threshold, which is 37.8. And then they would make sure that you didn't become hyperthermic. So they're not cooling you, they're just keeping you from getting hot. When they looked, the primary outcome was all-cause mortality at 6 months, which matters. And they found really there was no difference between the two groups. So in the hypothermia group, 50% of patients were dead within 6 months. The normothermia group was 48%. There was no statistical difference there. When you look at other things, secondary outcomes that really, I think, are important to the patient and their family, things like how well are you doing? There was no difference in modified Rankin scale at 6 months. So these are profoundly injured patients, no matter whether you cool them or not. They looked at kind of the risk of cooling patients, and there were a couple of things that jumped up. There were higher rates of arrhythmias with hemodynamic instability in the hypothermia group. So there's this small suggestion that, hey, maybe it's not totally benign to cool patients. But again, the primary outcomes, death from any cause in 6 months, were the same in both groups. And other complications, things like pneumonia, sepsis, bleeding, complications from the device were the same in both groups. And so, essentially, I looked at this study, and I think a lot of us looked at this study and said, hey, there does not seem to be an associated or any kind of benefit for cooling patients. We've talked to some folks who are really, really deep into this world of therapeutic hypothermia, and one of the things that they will come back with and say, no, this study, these are not the patients that we see in our emergency departments in the U.S. So if you look, the patients that were enrolled here, largely out of European countries, had lower rates of diabetes, lower rates of high blood pressure, less coronary disease with history of stents, and had really high rates of bystander CPR. So essentially, the argument has been made that these were overall healthier patients, but in our patients that we see in the U.S., they're sicker, so maybe it would work in those patients. I hear that argument from people, but for me, this study is enough to say, hey, we got to really think about, is this in the patient's best interest? And also at the system level, do we want to keep cooling patients in the absence of a study, a big, well-done RCT that tells us that this is a beneficial intervention?
Fantastic. Kevin, you have some response to this.
Yeah, I would like to jump in. I absolutely completely agree with that. And what a great job and great summary and a detailed article with limited time. I think where people get stuck on is we've probably all seen patients that benefit from therapeutic hypothermia, but the question is different. Is it therapeutic or beneficial to cool people, or is getting hyperthermic or not maintaining normothermia harmful? This is the study, and others have also suggested this, that it's really the prevention of harm while not allowing somebody to get hyperthermic, which is most important. So when we cooled a bunch of people, included in those groups were people who were getting hyperthermic, they did better. For the external validity question that Matt very eloquently raised, It doesn't matter to me in this study what the absolute numbers were. What was profound to me in this study was the lack of difference between the groups. And when you look at the randomization as well, amount of diabetes, male versus female, age groups, my goodness, they were absolutely almost identical in each group. So I didn't find much bias in one or the other. But I did find that in the secondary outcomes, they absolutely were the same. And that primary outcome of death, all-cause mortality at 6 months, there really was no difference. So I think we have to really focus on making sure that we don't actively cool people, but they did cool some of those people in the normothermic group when they got hyperthermic. They actively engaged in cooling them. Cool the right people, and you'll show that the right people who are salvageable will be saved and have a better outcome.
That's fantastic, and I would guess that we all agree on that, and we're all super happy that this article actually came out and laid this huge hassle, which really never seemed like it was totally viable, to rest. KK, I wanted to jump back just a little bit with you, and we had talked about some of the things that we could find by using the point of care ultrasound. You have compiled a list for us of some of the things that could actually change outcome post arrest with ROSC, what that we might be able to find on ultrasound.
Yeah, so I also wanted to thank Dr. Mahar, who in the comments had mentioned that Dr. Mahar wanted to check for pneumothorax during CPR. So I encourage this kind of interaction as well. Since this is live, we can do these things. But just thinking about during the code, we can look for a pneumothorax, we can look for cardiac tamponade, we can even estimate the ejection fraction, we can look for volume status by looking at the IVC. And a big thing we have to remember not to take more than 10 seconds for pausing of compressions, because then we do more harm than good. So do it quickly, be ready when they're ready for the pulse check, have it ready. Get in there, know exactly where to go, and check what you can check in 10 seconds or less, and then start the compressions again. But also the big thing, I think, is looking for cardiac standstill, because this can help us with our decision making on when to stop the resuscitation.
That's fantastic. We're going to progress on here. Thank you, KK, for that. And if you're not using ultrasound with cardiac arrest these days, time to get on that, because certainly there are things that absolutely could change an outcome based on that. Now, where we go from here is the patient became bradycardic. They got these medicines. They rearrested. CPR is resumed. They found a PEA rhythm. They found a VFib. They did some more shocks. And then you could go through all of this. We got a bunch of labs. We found the troponin was elevated, which we'll later find out was from a heart attack. And then the resuscitation continued, unfortunately, to the point that as we know now, that was unsuccessful. The last decision point I want to do, though, is to talk about just a few other things. And I'm going to try to cover these a little bit more briefly, because I want to make sure we get plenty of time to talk about some of the legal parts of this case. Of the 30 cases in the Bouncebacks critical care book, 3 of them did have legal implications to them. So for those 3 cases this month, as well as next month, I want to have a little bit of time to talk about that. I'm going to take this next question as far as the patient receiving lytics for suspected diagnosis of PE. This was actually one of the cases and one of the lectures that I did at Essentials of Emergency Medicine this past year, which was done virtually. And the short version of this story is that giving lytics to all cardiac arrest patients does not help. And the literature is very clear on that. But giving lytics to patients where we have a strong suspicion of PE, in the case that I had presented was a patient who had, we found out later, unilateral leg swelling, gave lytics, and the patient was resuscitated because of that, with then a later CT confirmed diagnosis of PE. That actually has, with several smaller studies, but has been shown to be helpful. There's some recommendations say that you should circulate that for 60 to 90 minutes. So it's a pretty big commitment if you're going to decide to do that. But if you do have a suspicion that the patient could have had a PE, either based on physical exam findings or a history that you get from a bystander, or maybe even a patient who's recent post-surgical, not all patients, but if you have a suspicion for it in that reason, and there's not some other reason you think that the patient would have arrested, to me, that literature is pretty supportive of giving lytics during that. So we talked about the cardiac ultrasound during the code. KK, I think we actually jumped ahead with your answer to that. But what I wanted to do before we do a whole lot more with the legal part, and we're going to progress there in just half a second, and I'm going to show you the results of the autopsy. And we're going to actually show you some documents from this that were shared at the trial. But Kevin, talk to us about code. Now, interestingly, on MRAP this month, there's a discussion between Swami and Scott Weingart about when a code should be called and how you correlate it with ultrasound. But we've all had those patients that are tough, that seems like it's over and you put an ultrasound on and there is still some cardiac motion. When do we call a code, for example, with this patient who is a witnessed arrest, where we're just not really getting anything with medications and shocks and chest compressions?
Yeah, I think quite honestly, it comes down to when there's a lack of viability, Michael. And viability can be just a patient doesn't have any, they're not responding to anything you're doing, or we run out of modalities or anything to treat what we think they have. And once you can determine that they've had adequate treatment with the resources we have, minimum of 30 minutes, I think is a rule of thumb to use, and they've gotten appropriate things, such as they have their airway managed. When they've had a shockable rhythm, they've received the appropriate defibrillations, appropriate medications, et cetera, and consideration of differential diagnosis that might deploy some treatment that might make a difference. Once you've done that, I think you're well within your right, and it's very appropriate to make sure that you do this for your patients also, but not put them through more than is necessary and preserve their dignity. Something I've also seen from many really good emergency physicians is recognizing that they may not be the only ones that have a really good idea during a resuscitation. And also, I will just share from a medical legal standpoint, it is very unfortunate when team members ultimately are deposed or are at trial as a plaintiff's expert against you. And even if it's unintentional, it can certainly happen. So for instance, if someone had a good idea and you didn't listen, or you didn't ask and you overlooked something, that can be a material issue for you. So going around the room saying, I think we've done everything, we've considered everything we possibly can. Anybody have any good ideas? Anybody even have any average ideas that we should implement? If the whole team is comfortable, and then I think ultimately, I've always believed that that bringing the family in when appropriate and when they're available, and I know some of this is optics, but not really pronouncing them until they've had a chance to say goodbye if the code is going on. Let them witness the hard work and the resuscitation that's going on. And I will tell you that people will really be very, very appreciative and won't challenge you and question what you did to try and save their family member. Thanks, Michael.
I'm glad that you said that. And I've had cases where I have, as an expert, seen for the plaintiff other healthcare members from that team. There's no place for humor or gallows humor during resuscitation, obviously. Even if people are nervous with that, curtains are thin and people not only outside the room, but in the room can hear things, and that can turn things in a way that, even if it's not your intention, would be an unintended consequence. So what happened with this patient, unfortunately, and a little bit after that 30-minute time that you had sort of said, Kevin, the patient was pronounced at 5:43, was apneic and pulseless, and the code was called. The pathologic diagnosis is the actual autopsy finding. The patient had an acute MI, and that she had a what they thought was the atherosclerotic involvement of the right coronary artery and the circumflex. So unfortunately, she did die from what they determined was an MI, and it sort of went with that chest tightness that she presented with, of course, with all of those risk factors. And so what I want to do now is explore how this played out in court. I'm going to show you some, I think, will be surprising documents that we have with that. And we're going to look at some of the different controversies. And we're going to go through that in a stepwise fashion with the four of those. The first one is the triage category. And as it turns out, with this hospital, they had just changed their categorization of the triage category to be that the patient was a triage category that was higher than they had, that it was a triage category that would have necessitated at least her being brought back at a certain time. And it was a little bit different than the hospital policy, and they actually came back later and brought that out. And I'm going to read some of that trial testimony right now. Question, I want to get some clarity for the jury's sake. She shouldn't have been a triage 1. Yes, sir. And you're standing by this statement. This is the plaintiff attorney interviewing the physician who cared for the patient. Yes, sir. I want you to look at Exhibit 30. It's the departmental procedure, correct? Yes, sir. It was revised in June, 4 months prior to her presentation. Yes, it's the emergency department policy to describe the steps taken when caring for patients over 18 with chest pain. Is that correct? The answer was yes. It says, for all patients, the standard of care who presents to ED with complaints of chest pain should be evaluated as soon as possible by the triage nurse to initiate appropriate steps to minimize mortality and morbidity. Yes. So what they did is they brought up the fact that the patient was categorized as a triage category 3, but she should have been higher as a 2 or perhaps a 1. I mean, probably a 2 is really where we should have been with that. But it was in contradiction to the hospital's own policy. And I just wanted to, and Kevin, this time I'm going to ask you for the very, very short answer for this. When a hospital makes a policy they think might be in the best interest of the patient, but there's no way they think they're going to be able to follow that policy, it seems to me that they're almost setting themselves up for failure.
You are. And the thing is, patients are not experts in medical care. They will listen to the battle of the witnesses on the plaintiff side and defense side. What they can easily understand, no matter what their level of knowledge of medicine is did you have a policy and did you follow it? And if you didn't follow your own policy, those cases are nearly impossible to defend.
So you want to give leeway with that. And that's why when you see guidelines now, they're going to basically say, these are guidelines, they're not rules. And that's why they call them that. And I think that we've had too much time where people have been sort of, hung out to dry by some of these things. How about documenting that it's busy? Should I document that it's busy? And I'm going to bring out Plaintiff Exhibit 31 here. And I have to say that this is a question that's asked to me just about as frequently as any when I give lectures nationally or with residency programs. Should I document that it's busy? And what I'll show you is this is the triage log, and this was presented to the jury. So if you think that you're going to document in this situation that it's busy and that's going to somehow get you off the hook because of an adverse outcome, the next question to you would be very easy to ask. How do eye complaints, a leg pain, abdominal pain, sore throat, or even flank pain, how does that somehow preclude you taking good care of a patient who presented with what we know now to be a heart attack was the etiology of their chest pain? So I'm going to read now a little bit of the discussion on that here. And they say, question, we agreed yesterday, doctor, that the most severe patient, the patient that was the most urgent, was triaged as a higher triage level, correct? Yes, sir. And I want you to look at the log. And is there a single patient with a higher level on there that has turned out probably should have been level 2? And the answer to them, there does not appear to be. There's the only way that they can answer. And so they went through and they asked the physician, what time did you come in? Generally, I come in at 6 o'clock. Okay. And you walk me through each of these patients and why any of them were more important for their care and somehow would result in worse care for this patient. So if it's busy, we all get that, but all of this is discoverable information later as far as the triage log. And if you're documenting that's busy, what you're basically saying, and this is to me, and Matt and KK, Kevin, I'd also be interested in your thoughts on this, but to me, some ways what you're saying is it was so busy that I couldn't take adequate care of this patient. I didn't call anybody else to come in. I didn't have the patient wait longer. I didn't get some additional testing. I didn't just go ahead and admit the patient or ask the hospitalist to come down. I just decided it was too busy to take good care of that patient. Am I thinking of that wrong? Because I feel very strongly about it, but what are your guys' thoughts on documenting that it's busy when you're in that situation?
Jump in real quick to get everybody started beyond your great comments, Michael, but you're exactly right. I completely agree with you. You're just explaining why you didn't meet the standard of care and why it's acceptable. Now, I tell you what, we've used documents in the past to show why there was a resource limitation in the department at that time, and you have to be very careful, but I wouldn't document it in your record. Leave that to your defense team. And I would also definitely say that you have to be careful about using this information later. I saw this backfire on a physician that got 2 lawsuits from the same shift.
Oh my
I
gosh.
was really busy, and so things were really difficult because of this one code. And then this other patient didn't get cared for well. Well, one case was used, as you just intonated, to also create allegations for the other case. And by the way, that person has the worst luck ever. I just have to tell you.
KK and Matt, any thoughts on documenting that it's busy?
So I have real
Yeah,
mixed
I don't.
feelings. Go ahead, Matt.
No, you go ahead. Go. Sorry.
Well, I have really mixed feelings about this. I mean, things are getting tougher and tougher with the pandemic, and especially in some of the smaller rural hospitals, trying to get patients in a bed, even we used to be able to just resuscitate folks and then admit them to our hospital or transfer them. But as beds get tighter and tighter, and across the nation, doctors are having to send their patients out of state because it's the only hospital bed available. I think that it's a question that as a profession, we need to look at this and figure out some solutions, because this is a real issue that is facing every practicing emergency physician right now.
What are your thoughts, Matt?
Yeah, I mean, I've been sued for a death in the waiting room case, and I was dropped fairly quickly. And it was a situation where we really were so busy we couldn't get folks out of the waiting room. And what that taught me was I don't chart that I'm too busy to do my job correctly. I think if you're in a situation like KK, like you're talking about, where you go on shift and you think that you're unable to provide a standard of care to the patient, I would say rather than charting that, I would talk to your administrators in real time. I'll talk to your risk managers in real time. There's certainly going to be actual disaster states, but I would hesitate to take the fall for a broken system as the physician. And again, I think I've seen this play out in court before, where the physician was very busy and they pulled a security footage where he had his feet up on a desk and his arms crossed. So I think you can ring the bell sometimes, but I would be very, very hesitant to chart that I couldn't do stuff because I was too busy.
Yeah, and I've seen that also, where there is a certain allegation made about a patient waiting a long time in the waiting room, and then it's the security footage, and the patient wasn't blue and wheeled back in a wheelchair as was alleged, but they walked back to the, treatment area of the ED. So realize that there's a lot of other people there that can sort of come in when you're sort of making some type of allegation. How about this next question here? And then we have some listener thoughts that I'm going to bring in too. How about a poor history being brought up at trial? I'm going to read you a little trial testimony with that also. Question. Now, in order to put the pieces of the puzzle together for what's causing chest pain, you need to get an accurate history, don't you? Answer from the physician, yes, sir. Question, you don't just take the patient's words for it. There are criteria for doctors to probe into what exactly the nature of the pain is. Isn't that correct? Those questions should have been asked. Is that correct? And the physician answers, yes, sir, they typically would be asked. And the question he comes up with next, and the reason they need to be asked is because we're dealing with something that could be missed, and you need as much information as possible to put the puzzle together. And the answer was yes. So I'm going to bring one other part of the history in here too when they ask about risk factors. And the physician and the attorney asked in a way that very good attorneys do. They only ask a question when they know what the answer is going to be. You never take a vote unless you know what the outcome is going to be, right? So the plaintiff attorney again asked the physician, let's count the risk factors. 1, diabetes, right? Yes, sir. 2, smoking, correct? Yes, sir. 3, hypertension. Yes, sir. 4, stroke. Yes, sir. 5, age over 40. Yes, sir. 6, family history. Yes. It's a bunch, isn't it? Sort of takes that knife that they just put in and twists it. It's a bunch, isn't it? And the answer is yes, sir. So before I reveal what happens, if folks that are listening, if you want to put into the chat the question that I have for you first, would you settle this case if you were the physician? So if people want to just sort of type in real quick, I'll give you about 20 seconds to do that. Be interesting to see some of the answers that come up with that. We're getting some yeses here. And without a doubt, I think that during the course of our careers, us wanting to spend that amount of time going through a trial, and 4 years is the average time with that, and try to defend yourself for care that really wasn't that great of care. Most people say they would settle this case. So I'm going to tell you what happens as a trial outcome. The jury actually did go. So the folks that said they settled is a good idea. Josh Russell says undoubtedly yes. I like that answer there. Julia Karp has 2 explanation points after her yes. Jury sides with the plaintiff. According to the newspaper report, quote, the jury hit the hospital with a $1.4 million verdict Thursday, concluding that the hospital nurses were negligent in their treatment of the late Stacy. So the physician actually turns out had settled the case and then was put on the stand and actually, interestingly enough, admitted their guilt during the trial. It's a very interesting trial. You can actually, find some of this with newspaper reports, and there's other ways you can contact me to get some of this additional trial information. It's interesting. It eventually did go through to appeal, and so there were some other things that sort of went with that. So what I wanted to do with our last 6 minutes here is get some of the legal thoughts. So we know that the patient didn't have a good history. We know they had a bad outcome. We know that there was some bronchospasm. Probably there was some wheezing. She was a smoker. We know her blood pressure was elevated. She did have a diagnosis of hypertension. It was true. But the question that the patient asked, the question with her chest pain, am I having a heart attack? Am I having a PE or dissection? That question was not adequately answered. Just going around with folks here, Kevin, what are your thoughts as some ways that we can keep not only ourselves, but most importantly, our patients safe when we have well-appearing patients who turn out to have very bad things going on with them?
Well, I think the first thing is trying not to filter what they're saying. If somebody says they have chest pain, we should look at that as an absolute statement. And remember, the greatest value in our diagnostic assessment is really, and you said it earlier, Michael, it's the history. It's free. But it also is limited based on someone's own bias on what they want to deliver to us. There can be also communication barriers, educational barriers, many different barriers, and people want to be well. They don't want to believe that they're sick. So if you start to believe what they're telling you, this is just like my indigestion, I really don't think it's that bad. I think I had this before. You still have chest pain that radiates to the back. That's a thoracic aortic dissection until I prove it's not with a CT. No matter what you tell me after that point, that is my conclusion. So I think you emphasize the history and absolutely use that medical decision-making note to justify your actions. Reasonableness is what is the basis for your liability. If your actions are reasonable based on your explanation, you can defend the care provided. And most of us are very reasonable with the choices we make based on the circumstances we have and the information given to us.
Kevin, I'm going to keep you up here just a second before I get KK and Matt's thoughts on this. Josh Russell asked a question to the point that KK made about the pandemic and limited resources, extreme circumstances. How protective are some of the dot phrases stating that the care was delivered during a healthcare crisis / national emergency? What do you think about that, Kevin?
This is one of the exceptions, I would say, if you document it carefully, where there is such a resource limitation, it should change the standard of care. In other words, not that you're ever going to say, well, there's a reason why I couldn't deliver the standard of care to my other patients because of this. I do think that the average patient, the average healthcare consumer understands that there is an overstripping and outstripping of resources during the pandemic, and you can't be all things to all people. So I would take a carefully worded phrase, such as pandemic related, resource limitations during this shift, but be very careful not to apply it to this given case. And not make it about you. I was too busy. I was too inefficient. I couldn't get it done. The system did this to me, the environment did. And I'd be careful how you word that and make it a macro that everyone agrees upon so you're not making it up on the fly.
Matt and KK, some final thoughts. What are some take-home points that you're going to incorporate into your practice next time you go on shift based on some of the things we've talked about tonight? KK, you want to go first? And we'll let Matt give us the grand finale closing arguments.
No, I just want to retire.
Right.
No, I think, our jobs we're well trained and we know how to take care of patients. And sometimes we're on system problems, like the pandemic is kind of showing us that we can kind of be in a no-win situation, and we know exactly what we need to do because we're well trained, but not having the tools and the staff and the beds and the resources puts us in a tough situation. And so all we can do is put one foot in front of the other and care for our patients from the heart from the knowledge base that we've built and do the very, very best that we can.
Matt, give me some closing thoughts while I put the QR code up for folks who haven't yet scanned it to get their CME.
Yeah, Kevin said it well with if you have pain that goes to your back, that's a thoracic aortic dissection until proven otherwise. But I think one of the things that to keep in mind is failure to consider is one of the biggest kind of allegations of malpractice. And so for every single chest pain I see, even if, Mike, you punch me in the chest and I go in, I say it's unlikely ACS, it's unlikely aortic dissection, it's unlikely PE. In some of the situations, I don't have to do a test if I think my pretest probability is low enough. But Kevin, you nailed it, that when a patient comes in, we have to think about the big bad things that we could potentially be missing.
You know, it's so funny you said that, and I'd hope to end with you, but I just I have to say one thing. When I was a medical student at Ohio State, they said if you think about PE, test for it. And I have to say I disagree with that, because you should always be thinking about it, even if you get hit by a baseball, get punched in the chest, right? That doesn't mean that you need to go further, but you need to consider that in your differential. Just like you said, you need to consider. So, for example, thoracic aortic dissection, the only way to get the answer, not a chest x-ray, not a dimer, but a CTA. But if you have that pretest risk, maybe because of lack of an alternative explanation, or maybe because of those above and below diaphragm symptoms, unexplained tachycardia, et cetera, if you do, you need to get the study. But if you don't get the study, you need to put something in your documentation, why you consider that and why you thought that that was not likely enough to do the test for it. So, Kevin, I know you answered that last question. I didn't give you an opportunity for closing thoughts. So if you want to do that, and then we will actually legit close things down here for the night. And folks can, if you'd love to join us, we'd love to have you for our next Bouncebacks book club. We'll be with Swami, we'll be with Scott Weingart, and this will be a case of a patient who has anaphylaxis and an adverse outcome, which also ended up going to trial. So, Kevin, the short final closing thoughts from Lori.
Short final closing thoughts. First of all, thank you, Michael and Matt and KK. But I would just say you don't have to document volumes to reflect the great care that you delivered, but you have to document accurately and make sure that the key points are there. You don't have to spend all day and all night creating, a 5 or 6 page document. Matter of fact, that can be a problem in and of itself. Hit the right points, be thinking about what it is you might have missed, and make sure you've done the things to make sure you haven't, and then get that in the medical record. Thanks, Michael.
Everyone, thank you so much for joining us tonight. I know your hour of time on a Monday night is valuable, and hopefully we are worthy of that. We would love to see you back the first Monday of February, talking about another patient with unfortunately adverse outcome. KK, Matt, Kevin, thank you so much. It's been a pleasure doing this with everyone, and we'll look forward to seeing you all next time. Thanks again.
Thanks, guys.